All right. That was fast. Y'all settled down well. Excellent. Well, thank you so much for being here. We're very, very privileged. There's lots of places you could be on a beautiful Thursday afternoon. But welcome to North Carolina. For those of you who aren't from here, this is how it is every day in North Carolina. 70 degrees, whether you're inside or out. It's wonderful. But we are privileged to have you. You could have been a lot of places, and we're thankful that you chose to spend some time with us. So a couple introductions. You probably saw it, but bathrooms are down the hallway. We'll have refreshments here. We're going to have a reception later, which we'll talk about. This is the Proximity Hotel. It's a very special hotel. It was actually the first hotel in the country to get this LEED Green Building Award. And so for those of you who are staying here, I know a lot of you are, but some of you couldn't get in because we're also hosting I think it's the round of 16 NCAA women's tournament at the Coliseum tonight. So if you see some very tall women walking around, you'll know what's happening. But to get the Lean Award, everything okay? To get the Lean Award is pretty interesting. I didn't know this. I looked it up today because last year I just said it was really green and a lot of recycled things, but I thought that I needed to share this with you. So 87% of the construction debris was recycled. 40% of the building materials came from local suppliers. Over 20% of the construction is from recycled content. They restored 700 feet of a stream that's out here that you'll see when we're out doing our reception on the veranda. Installed the first regenerative drive elevators, which sounds very biologic and orthopedic, doesn't it? The first regenerative drive elevators in North America, which generates electricity as it goes down for the other one to go up. So it creates electricity for that to happen. Provides natural lighting to 97% of all occupied space. There's 100 solar panels on the roof. That the reason we have this nice ambient light is because it can't go up any higher. It's just what the solar panels give us. And then for those that are staying, you'll notice when you flush, it kind of flushes quickly, saves 40% more water than any other hotel in the country or something. So it's a locally owned hotel, and we're thankful to be here. It's got a really nice, elegant feel to it. So it's a great place for our rather intimate meeting. So we had our first Valere Summit a year ago because as we're going to tell the story, there was a lot of interest, and we just said, please come to Greensboro in April of 18, and we'll share it one time very efficiently, and then we're happy to help and whatever. So we're back again. We have a bigger crowd. It's a more diverse crowd. We have physicians, payers, industry leaders, lots and lots of different folks here, which is great. So the creative energy and the collective intellect is unbelievable in the room, and so we're going to tap into that tonight in our panel discussion. Tonight is simply, we're going to share the story of how we got from where we were 3 years ago to now. And then we're going to have what I've been looking forward to for 12 months is our payer panel. So when we left a year ago, I realized one of the best things we can do as assistants, as consultants to our colleagues, is to bring the payers to the providers. And so we settled on a course to get to know the payers, get bundled contracts with payers, and then hopefully introduce the payers to the providers in the network that we reach out to. And so tonight we're going to have a payer panel, and I'm going to ask some questions, and you're going to ask some questions because it's a very complicated space, and we're all learning. And so we're going to keep it respectful, but we're going to ask some really tough questions. They're going to ask us some questions, doctors and administrators. So it's going to be a lot of fun. So the Greensboro story. So starts in 2015, where for those administrators and some physician leaders might be familiar with the Orthopedic Network News, and it's just an annual or biannual now, I think, newsletter. And I noticed in it that we were ranked 8th in the country here in Greensboro for Medicare volume. So there's 4 fellowship-trained total joint surgeons that formed this company, and collectively with our colleagues in the community, we were 8th. I had no idea. And then a friend sent me this that said we were the #1 place to have a knee replacement in America. Now you would think my hospital would tell us that, but it was actually some random person from a different state, congratulating. And so we realized we had this lack of alignment. Of course, we've done it for a long time. Lack of alignment with our inpatient system, which is not an unfamiliar story. So we got to thinking. We saw the SG2 forecast that says that half of total joints are going to be outpatient by 2026, and we started seeing news, all of the throwaway journals and so forth, and slowly in our Journal of Arthroplasty, we started seeing articles about outpatient total joints. So we saw what was coming with outpatient total joints. So we said, well, we're the 6th highest volume. The next O&N in 16 said we were the 6th highest volume in the country in Medicare. We had excellent outcomes. We had poor alignment with our hospital. We knew that the delta between the inpatient and the outpatient facility fee, DRG, whatever you want to use, was about 20 grand. Total joints were moving to outpatients across the country, and we were building our own surgical center with all of our surgical colleagues in the community, which is right over there, and many of you got to tour it earlier. We're going to run another tour when we're done tonight if you want to go. And we were shareholders. And so all of that, we said, well, maybe we should consider doing something in the bundle payment outpatient space that we had learned through the BPCI program. I put this slide in just to make sure, because we do have a lot of different folks in the room. I think everyone knows this, but I don't want to take anything for granted, that historically, you know, the fee-for-service concept, everybody submits a bill, and the collective 90-day spend for that episode is somewhere between $35,000 and $90,000, depending on which community in the country you're referring to. Actually, even in this state, it's almost as big of a range. Where in the bundle payment, the money comes to someone first, they negotiate all the downstream providers, and they're paid out from there. So that's just to make sure everyone understands what a bundle payment is. And the orthopedic surgeon is represented by the hammer. So this is the first reality that we came to as the 4 of us from 3 different orthopedic practices in this community spoke about, that we have a broken shovel. There's a book that I read years ago called The Age Wave, written by Ken Dickwald, who's kind of a guru of the baby boomer generation. Brilliant man. And the concept of the book was the boomers are getting older, and every facet of our country's economy that they have hit through the years has made an unbelievable impact. So 1956 was the most high schools ever constructed in our nation's history because the boomers were coming. Then college attendance was at its highest because the boomers came. Well, what's happening next? The Medicare population is going to double in the next 10 years. So double in the next 10 years. So the concept was get a shovel, dig it in front of the boomers, and make some money. And then what I realized about 10 years ago was my shovel broke. Like, I didn't go into it with a shovel in mind. I just went into it because I enjoyed woodworking and tools and this and that. But I had a shovel. I had a good tool to do a total knee. But I was not in control of anything about that industry. Reimbursement's going down. EMR, overhead is going up. And so I'd spent all this, 14 years dragging my family around with all this money, and I got a broken shovel. And that's the reality, is twice, Medicare is going to double in the next 10 years. And guess what's going to happen to the number of orthopedic surgeons? It's going to get cut in half because of the generation. No one's going in. Well, some are going into medical school, not many. Doctors are retiring earlier. So reality number 1 is there's been an investment by the surgeons that are doing hip and knee replacement that if we don't take care of them, if we don't recognize the value of the surgeon, then we're going to have a national healthcare crisis. And then multiply that by cardiology and oncology and plastic surgery and all those other things. But the first reality is, remember, there sometimes is an opportunity for a market correction, and we believe this is one of those times. The second reality is that 100% of the clinical decisions that are made for the episode of care of a joint replacement is made by the surgeon. If he's going to do surgery, where he's going to do surgery, the implant he's going to put in the patient, whether they go to a skilled nursing facility, home health, how many outpatient visits they get at PT, durable medical equipment, medication, all of those clinical decisions are made by the surgeon, and all of them are financial. And so part of our reality is we want to educate physicians and help them take ownership of the business so that we can control costs and add value. So the opportunity that we looked at was to create a model where patient care is first, but attention is given to the value of each decision, and the surgeon is accepting responsibility, risk, and reward of this new paradigm, because after all, surgeons, it's our business. It's no one else's business, it's our business. They came to you for their hip or their knee replacement. They trust you. You became excellent at your trait, and you need to pick your head up and realize that they're not just clinical decisions, they're financial decisions, and so you need to play quarterback. And so we're here to help. We're here to share what we can learn and to learn from you. So in 2015, Eluzio, Olin, Rowan, and myself formed Delta Joint Management. It was just an idea that since we were in different practices, we needed to form a company. You don't have to form a company, but we formed a company. we hired Donna Garvey, who's my practice administrator, and since she just takes care of one little doctor, we felt she had the bandwidth, which she has proven that and then some. February, we signed a consulting contract with our own surgical center to build an outpatient surgical service line. And so they began to pay us, and we reinvested that into the business. We signed our first outpatient total joint bundle, the first outpatient total joint bundle in North Carolina with North Carolina Blue Cross in October of 2016. First 90-day prospective outpatient total joint bundle. In January of 17, we started doing bundles, but we only did partials. The reason for that is we were at a different surgical center up the road that was very, very small and very, very old, and we were a little concerned about doing total joints in that facility while this one was under construction. So we used that as an opportunity to really just build a bridge into the model. So we were doing 3 to 5 partials a month. Donna was watching the money flow through. We were watching our clinical pathways operate. The nurses were learning to mix cement. So it really worked well as a bridge. And then in August of 17, we opened the Surgical Center of Greensboro across the road and began our full-fledged total joint program. We've done over 350 90-day prospective bundles. And we have bundles with North Carolina Blue Cross, Aetna, Cigna, Bridge Health, and we've agreed to terms with MedCost, as well as our first Medicare Advantage bundle, which is very interesting, with Aetna. So we have grown tremendously in just 1 year. So our major goals as Delta Joint Management was to build and lead a world-class outpatient joint program. Pretty robust goal, but as I just shared with somebody, why not? We have a world-class outpatient facility, the largest in the country, 60,000 square feet. We have beautiful accommodations here. We call this our overflow facility for patients that we can't fit over there. And so and we have great fellowship trained total joint surgeons in a wonderful community. So our goals are high. Secondly, to lead the negotiations with the payers. I had never talked to a payer until 3 years ago. And that's been a journey. It's been fun, and we'll talk about some of that. But you need, as quarterback surgeons, to be at the table leading the discussion because, again, you make the clinical decisions, and they are financial decisions. And then to control the bundle. We want it to be our own convener. From our BPCI experience, we had a convener, and they gave us data, and they took 35% of our savings. And after a while, we wondered, why are we giving them 35% of our savings for an Excel spreadsheet? So can we just learn to be our own convener? And then we said, well, if we could learn to be our own convener in the commercial market instead of Medicare adjusting our target price down every year, that would be really great. And that's where the idea came from. So to have an outpatient total joint program, and this is not new news, you need clinical pillars, we call them, pre-op, peri-op, and post-op. So inclusion criteria for the patient. We also have inclusion criteria for the surgeons who can participate. There's 11 of us now in Delta who do surgery at the surgical center. But there's inclusion criteria for the patient. There's case management. You'll hear about that tomorrow. That is certainly the secret sauce of all of the clinical pillars. Perioperatively, you'll hear about standardization tomorrow, anesthesia. Postoperatively, again, standard protocols for physical therapy, home health. We're going to take a deep dive into the clinical pillars in our morning session just after breakfast tomorrow. You also have business pillars. We've learned a lot of business. You need an executive leader such as Donna. Many of you come from an orthopedic group where you have a CEO. You need an aligned ASC partner. Some of the groups here have 2 or 3. Some of them have one that they share with a hospital and a joint venture. It's going to look different in different communities. We recognize that, and that's part of our role in the last year as consultants is to go into the community and say, well, based on our experience and what we know and what we've learned, here's how we would position you for success, et cetera. You need an informatics platform. One of the things that we have built, which is our product that you can use, is we needed a product that clinically the case managers could risk stratify the patient to make sure they were appropriate to be done in an ASC, and then build a plan of care to care for the patient for 90 days before the surgery ever happens, and then measure their outcomes with patient-reported outcomes, submission of data to AJR, all of that stuff, and that's what payers want, and that's what we need to be doing. So we build that clinical side, but then on the back side, which is the side that I still don't understand, but only Donna does, is the claims adjudication piece. So there's this whole thing that goes on with claims fee-for-service that's super complicated and is really difficult for the payers just to turn a bundle on because of how things have always been done, but they have to be done. They're their members, people have paid their insurance premiums, and so they have to take care of them. And so there's a process that's extremely complicated, that has to operate in the background. And so we plug that into our informatics platform. So we have the clinical side, and then we have the claims adjudication side. You need a good regulatory attorney, which ours is wonderful, and it's from here in Greensboro, from a statewide firm. And is it legal for doctors to do this? Is it legal to have contracts with downstream providers? So we spend a lot of time and a lot of money with a really good attorney, making sure it's all legal and that it all works. And so we've learned a lot, and we're willing to share that as well, with you. Risk solutions, the biggest thing that gave us heartburn at the beginning was if we were going to take the risk in order to receive the reward, what in the world were we going to do with the risk? We're risk averse, we're conservative people, we don't like risk. So we went on a journey to learn that, and you'll hear about that, a little bit more about that tomorrow, but there are really, really good options. And then an aligned payer partner. The most difficult thing, and the reason we're going to have a panel, is because it takes a lot of time, a lot of communication, a lot of understanding. It's just foreign soil, and so it really just needs it just takes time. And so we're going to listen to our payers, learn from our payers, and a little bit on the panel. This is my favorite slide. If my wife's not in the room, she needs to. She was helping at registration. This is the slide where when she says, honey, what in the world have you been doing with your time outside of surgery and seeing patients? I show her this slide because we're in the middle there, and every arrow to each one of those things is not only a contract, but a relationship. So I can tell you the name of these people. I can tell you where they're from. Sometimes I can tell you that they enjoy duck hunting. Sometimes I can tell you that they have a dog. That I hear in the background when I talk to them. Sometimes I can tell you, so we've gotten to know and we've built a relationship of trust, I hope, with these people, because we had to negotiate all of the rates with some and just the opportunity to care for patients with others. And so this is a lot of work, but it's work that you can do and you need to do because it's your business, surgeons. The ones at the bottom, those are our 3 orthopedic groups. The payers are on the left-hand side, self-insured companies, and then all the other stuff. So what we did was we took that very confusing slide with lots of arrows, and we realized this, that what it really takes in your community to do this is what we call the triangle of alignment. You need a group of physicians. It can be a group of physicians out of different practices. It can be a group of physicians within one large practice. That doesn't matter. You need a group of really good joint surgeons. You need a payer or payers who are aligned and they want to see that site of service shift occur and is willing to listen and work with you on how we can make that happen. And then you need an ASC or a group of ASCs. Okay? So those are the 3 things you need. And I think the secret sauce is physician leadership, because until you get a physician champion or a couple of physician champions who are willing to be businessmen as well, you're really not going to shift that side of service. They're going to say, why would I do that? I'm doing fine surgery over at the hospital. So how does the bundle work? The insurance company pays the bundle in full prospectively. Prospectively, the insurance company pays the bundle. Delta then contracts and pays all the downstream providers, which include the surgical center, the implant, the surgeon. You get your fee-for-service fee. The anesthesiologist, DME, home health, and PT. We're our own convener. So after paying the downstream providers, we reinvest the money back into the model, which allows the site of shift to occur by the following mechanisms. We invest in case management, we invest in informatics, we invest in a metric-based incentive program for our surgeons, that if they do a great job, we're not just paying them to do gloves on, gloves off. We pay that with the fee-for-service payment. We're paying for what happens when the glove goes off until the 90th day, for them to pay attention and take quality care of the patient, listen to their case managers, answer their telephone, whatever they got to do for the patient to have a perfect outcome at 90 days, that's what we're paying them for, and there's a program in place to do that that's metric-based. And then general overhead at cost. There's attorneys and admin fees and all that kind of stuff, so there's some expenses. So we take the money that is the site of service shift delta and we invest it into this program. You can't simply take a patient from Cone Hospital, do them at the ASC, and expect them to do well. You can't do that. There has to be a program in place, and we'll tell you how to do that. So this fellow, Professor Michael Porter from Harvard, coined this whole value term for value-based care. So I haven't seen anybody take a picture of a slide. That's okay. I'm not offended. But this would be a slide to do that of, or at least a pretty simple equation to remember. So value is outcomes divided by cost. So every decision we make, we put through the value filter. It either has to improve the outcome or keep it the same and have a reduced cost. So we've achieved the double bonus of value, where we actually have improved outcomes in our community and decrease the cost. Both. Very rarely do you see that happen. So the site of service shift, once upon a time, the payer said, why would you need X amount of dollars for that bundle when it's just a simple site of service shift? I won't name names because it was a long time ago and none of us knew what we were doing. There is nothing simple about this. This has been a very complicated effort. Totally possible, but it's not simple because the inpatient hospitals have PT departments, case management departments, scheduling departments, accounting departments, lab departments. What does our surgical center have? We don't have departments. We don't have any of that. So you have to design a program that surrounds the patient and assists the surgeon to make allow the site of service shift to occur. So to capture the high volume arthroplasty surgeon, we've created a way for the surgeon to be supported clinically and create a financial win for all parties: patient, surgeon, payer, and the ASC. So what you see around the country, the SG2 forecasted that we would be ahead of where we are right now in the country with volume of total joints. And the reason we're behind on the curve, there's no incentive and there's no program. Like what would possess an orthopedic surgeon who's been doing 5 or 10 total joints in the same room with the same staff for 10, 15 years, getting great outcomes, to do anything different? So what you're seeing is in the ASC, the sports medicine guy that does a few total joints and a bunch of arthroscopies, he's going, hey, I got time, I got my assistants right here. So you're seeing those guys doing arthroplasty, joint replacements in the ASC, but you're not getting the guys that are in this room that are doing hundreds, if not over 1,000 joints, because you haven't given a clinical program or any incentive for them to move it. And that's what we tried to do. That's what we're trying to do. And we have 359 bundles. So we're getting our highest volume. In fact, our highest volume guy didn't even have block time at the surgical center, isn't a shareholder at the surgical center, and is still bringing volume. So what a difference a few years make. So that was then, and now people call us every week and say, what in the world are you doing? We're the fastest growing outpatient joint department in the country. We're the only ones doing 90-day prospective bundles with multiple payers. And so we've been featured. The advisory board is one of the largest consulting firms in the country, and they did a case study on us. And then Orthopedic Network News, that I didn't even know what it was in 2015, quoted me in 2018. So we've gotten a lot of attention, which is kind of all fun, but at the end of the day, if we're not helping surgeons take care of patients, we really did not grow up to be consultants, so we're very reluctant consultants. We're really here to help surgeons. We're here to bring payers, introduce them to surgeons, give them what experience we have, and learn from those that have done more. There's some surgeons in the room that will be on the podium at some point, where we'll be asking them questions because they've done far more outpatient joints than we have. They just haven't done them under bundles, and they're wondering, why did I do that, or how do I, we need help, and that's why they're here. So just for some vocabulary, Delta Joint Management was the story I just told. The reluctant consultants, we formed Valere because we kept spending so much time on the telephone. We billed an hourly rate as physician leaders, and we were kind of charging it to Delta, and it wasn't fair when we were talking to people in Washington State and California and New York, whatever. So we formed just a sister consulting company to Delta, and that's what Valere is. And we have a couple of different partners. So I've mentioned Matt Olin, Frank Rowan, Frank DeLuzio. Mike Ludwig is here as one of our business people. Mark is our software developer for the product, and then Don is our executive director, and we're all equal partners in the consulting. But what we do is we assist MDs in creating their own Delta or Delta-like situation. Again, you don't have to form an LLC, you can if you want. We assist industry partners in helping the site of service shift occur because it's important to them to save money as well, to connect payers to our Valere network of physicians. And then our informatics product, which you'll hear about tomorrow, the necessity is the mother of invention. We did not set out to do it. We used a product, it didn't work. We said, hey, let's hire somebody and build our own, And so it does case management, clinical informatics, and bundle adjudication, and you'll get a demo of that tomorrow. So with that, I'm going to pause and answer any questions. Again, we're going to unpack the clinical pillars and business pillars, and we're about to talk with our payers. But does anyone have a question about anything that I said so far? Or did I just totally overwhelm you with information? Any questions? Excellent. So if I could have our payer panel come up, that's what we really are here to listen to. So come on up. You guys know who you are, and ladies know who you are. And while they're coming up, I want to thank our summit sponsors, DePuy, Synthes, Zimmer Biomed, Pacira, Heron Therapeutics, Reflection Health, Arthrex, and Compass. Can't do it without them. Really appreciate it. They're partners in the industry. We didn't just open it up to vendors of any kind. We opened it up to vendors who we felt brought value. Am I missing a chair? No, we're good. Frederick, I think you get to sit down here by yourself. No, come on down. There's two. Come on, Jordan. Yeah, come on. All right. All right, well, first of all, I have been waiting for this for an entire year, and I was going to pass out rotten tomatoes, but I've grown up a little bit since that, thought about 6 months ago, 6 days ago. But I've gotten to know each of the people on this panel over the last year, Don and I have, and it has been a pleasure. There's no one that we don't have a good relationship with, that we've learned about them and learned from them, and so it really is an honor to have them on stage. We have spent a lot of time with these people, a lot of time, them getting to know us, the questions we have, the growth pains we're having, and for them as well. So here's how this is going to go. I guess since I'm up here, I'm in charge, I get to pick who I ask questions to, but we want audience participation. So I have some questions. Some of them are real important that I want to ask, but they're really, I want to hear from you and what questions you have, okay? And it doesn't matter if you're a surgeon, a payer, ASC administrator, implant, doesn't matter. Your questions, that's why we're all here. We're all from different backgrounds and that, which makes the room very, very interesting tonight. So this one is just going to be one sentence answers. I feel like a reality TV game show host or something. Huh? Oh yeah, sorry. Thank you very much. I missed a piece of paper. And that is even though I know them, y'all don't know them, and I need to introduce them. I could let them introduce themselves. Actually, let me do that. Let me have you introduce yourself, because I want you to just share your title in your company. I know you're all like national vice presidents of value-based care, but that's not what you are. You all have some different kind of title. So Jordan, we'll start with you. Frederick, move on down the road.
Very good. First of all, thank you for having us. Appreciate the opportunity to be here. Dr. Lucy, very fantastic, the ground that you've covered in a short amount of time, so appreciate the opportunity. Jordan Rigel, I am the National Vice President of Medicare Payment Strategy for United Healthcare. I've been with the company for about 12 years, and certainly bundle payments is a cornerstone of our value-based incentive model as we look to help promote and partner with providers like Delta and others to help advance quality care.
Excellent. Thank you. Frederick?
My name is Frederick Reese. I represent about 300 member companies throughout western North Carolina. We define that from I-77 west. So that would be Hickory, Morganton, Gastonia, and Asheville. And really we are a nonprofit, are the eyes and ears of those 300 companies, finding them effective cost reduction solutions that involve their employee population. And so we provide a staff that addresses their regulatory and legal issues, and then we do groundwork to find innovative ways to reduce their healthcare spend.
Good stuff. Sean?
Sean Strom. I'm with Aetna. I run an area called Value-Based and Strategic Contracting Analysis, which really is sort of what I would describe as research and development for our value-based programs, looking at performance and coming up with new programs.
Jake?
I'm Jake Young. I'm with Blue Cross and Blue Shield of North Carolina. My title is Director of Network Pricing, which sounds like, what in the world is that compared to what we're doing with bundles? Sort of been tagged with that, but my team's really responsible for all our system work we do. We provide data to our contract teams. I've been tagged with sort of leadership for the bundle program, which we've really grown with partners like Dr. Lucy, especially in the prospective space. So appreciate you having me here tonight.
Good evening, everyone. Joe Bailey, representing Cigna Healthcare. 18 years with Cigna next month, so have a wide range of experience in multiple teams within Cigna. Currently, my title is Director of Program Advisory Team. Essentially, what we do is work with our market partners across the country in about 11 specialty categories for value-based work. So really education, consulting, multiple things that we do. So we wear many hats these days.
Good evening or afternoon. Wanda Owen, Vice President of Operations for MedCost. MedCost is a network, but also a TPA administering self-funded benefits for over 400 individual employer groups. And my title is Vice President of Operations, and similar to the others here, operations doesn't really align completely with value-based, but I am part of a team that is working with Dr. Lucy and his folks to implement this solution and find ways for very cost-effective, excellent care for our members. So,
Great.
thank you.
Hold that mic, Wanda. All right, so first question is easy. It's a pitch across the plate, really, so it's only one sentence. You can't mess up too bad, okay? So lots of trends that come and cycle through healthcare. And of course, the Obamacare kind of launched the BPCI and the value-based care, ACOs, bundles, et cetera. Do you think bundles are here to stay? Do you think it's a way of the future? Or do you think it's just a little flash in the pan, and when some other president gets elected or something, we're going to go back to fee-for-service? What's your view?
So we have tried bundles in different ways, and I think if bundles can be more effective, similar to the manner in which they are being administered here, they have a great future.
Is it one sentence?
I did.
Yes. No, I absolutely agree that they are here to stay. I think our employers are demanding a change, so we have to work with our partners up here to help implement that change.
I would agree 100% with Wanda. I think the key is going to be how well we operationalize, and that's both on the payer side and provider side.
Yeah, I think they're here to stay. I think you're going to see bundles apply to a wider range of episodes and conditions, not even just a surgical procedures being built, in my mind, for outpatient programs.
I would agree with everything they said. Since I first became aware of a bundle, I'll say 3-4 years ago, before Dr. Lucy's business, all I'm seeing is growth in this area. And so I anticipate we're going to continue to see that as long as the free market is allowed to operate.
Jordan?
So yes, with two caveats. One is bundles are going to evolve. So bundles as we see them today are going to expand in breadth and in scope. We're going to see bundles become more complex, and as providers get more astute at taking on risk and managing that patient risk, we're going to see bundles become more complex as well.
Great.
That's the first one. I would say the second thing is I think we're going to see an evolution of bundles into a natural progression of service line capitation. Not in every market, not in every situation, not for every subspecialty, but I think that's going to be a natural progression as bundles evolve over time.
Interesting. That's good. So start with Jordan and go down the other way. So what is your company's current appetite for bundles? How many resources are you pouring in? I mean, what's your appetite?
So United Healthcare just spent $10 million investing in a new convener capability to help providers be successful in bundles. We've spent upwards of $8 million investing in system capabilities to be able to adjudicate prospective bundles appropriately. So the short answer is a lot, right? We're doubling down on this. We see this as a huge future state opportunity, not only in working with specialists in new ways, but also helping ACOs and other integrated systems use bundles to help drive improved outcomes and success within their vertically integrated systems. So bundles are definitely here to stay.
Right.
I'm speaking for employers now, and a lot of our larger employers were already using bundles, but in an international setting. They were sending patients to India, Costa Rica, and what I see is an opportunity to bring that back domestically. And they're very interested in the domestic value of having bundles in a local market.
Instead of the medical tourism model.
Instead of the medical tourism, an hourly employee is not comfortable getting on a plane and flying to Bangladesh, but they will come to Greensboro. And
Wow.
And so this is enormous opportunity.
So Ed has invested in our claim systems to build out the capability to do basically all the PPCI bundles plus maternity. We see the number of bundles expanding in the future, as well as investing further to be able to do things like differentiate plan design based on our monthly progress.
So, in case you haven't heard, we've got a lot going on at Blue Cross in North Carolina in the value space. So bundles is a piece of it. Bundles sort of predated what we've done over the last couple of years with the move to value with our large systems. So I would say we're definitely looking at expansion, definitely looking at the growth, looking at additional types of episodes, not just a procedure-based, but some getting into some of the chronics. But the key is going to be, and we're really focused and committed to prospective bundles. I'm not saying we won't look at some types of episodes for retrospective bundles, but it's really, as Dr. Lucy pointed out, it's hard to start this when you're starting from scratch on both sides. So for us, it's the key to pick good partners and try to scale those partners, scale those episodes and those procedures to start, for sure.
I would say that Cigna certainly has an appetite as well for bundles. We started in the episode arena in 2015 with a retrospective focus for 5 specialty categories within, orthopedic models, 6 specialty categories. So we've got just about 4 years experience in the retrospective view. We launched our first day of surgical bundle for total joints last year, mid-18, and that's really working with our large physician groups and our ASC partners, and we're looking to continue to expand that. So as many of you that we met earlier today, you're going to hear this spiel again, where we're really, there's an evolution with the models and how we continue to build out 2019, launching in 2020.
Similar to my payer partners up here, we are making investments in our ability to adjudicate. Dr. Lucy said earlier, it is a very complex system, and it is a very complex process behind the scenes, and so the investment in both systemic and resources to be able to support it. What Frederick did not say when he introduced himself is that MedCost is a self-funded administrator for many of his clients, and so we are also making investments in how we educate the opportunities here, so marketing and things of that nature that we can actually bring to our clients in a way that brings more visibility to it.
So I want to follow up on something you said, Jake. You said that the prospective bundle was what you felt was the correct thing, and Joe mentioned they just progressed, evolved to a day of surgery. Why do you think the prospective is the way to go, and then we'll let others agree or disagree with you?
At least for us, I think for the payer, once you get the pipes built, so to speak, and you get away from the fee-for-service, and when we talk about the pipes built, we invested quite a bit in front-end pricing systems that can price the bundles, and we invested in back-end analytics systems. So for us, we've invested money, so we're committed to that model because we feel like the value for the member, the simplicity, the outcomes that we're seeing when we compare what's happening with our provider partners that do and don't do the bundles. We're seeing the results. We see patient satisfaction surveys come back to us and say that they're much happier with that. So I think the perspective for us, that's where we've seen at least the value.
Okay. Anybody agree or disagree?
I'll just add, I think the one thing that is missing if you do a retrospective bundle is sort of that member's perspective. If they do a prospective bundle, they know what their deductible and co-insurance is going to be. It's the transparency in pricing, which is, I think, a very important part of the sort of everyone's in that approach.
Just a surgeon in the crowd want to share why we might think a 90-day prospective bundle would be more clinically appropriate. Do I have to do all of the talking?
I would just say that it actively engages the person who is decision making. I always found it arbitrary with 90 days, especially since the low-hanging fruit is a product that you can reproduce like replacement. So to me, it should be a 90-day for episode 1, but there should be a modifier to get survivability of your product past 2 years, looking at the data to what the long-term or longevity aspects are. So, but I mean, I think this is a great swipe at trying to gauge this relationship. This is foreign for most of us to have this kind of frank discussion. We've been so defensive in our posture about how we are trying to achieve the same goals. But yeah, we actually now care. You know, I'm actually looking and not just pawning it off to somebody else who's in one of these stated departments.
Yeah.
I'm actively managing this, and so I can steer it knowing the patient and the background, but I'm coming to a day number 40 of what that means to prevent problems. So,
Don't you think also, Sean, that when, before, say 10 years ago, we would just do the surgery, let the departments take care of the patient. We kind of signed a blank check for home health, PT, SNF, and they were staying 21 days, 35 days of home health, 82 days of outpatient PT. They were making a lot more money than anybody else.
as you put out there, there's no incentive. All it is was more time for us. There's no change for us.
Yeah.
So it was just more labor that somebody else is going to get paid for that anyhow.
Right.
Just assuming more responsibility. But now I think, now that we in BCPI round 1, even though it didn't have the for a lot of us, it wasn't the magic solution that we were looking for. It made us better clinicians of managing the entire episode.
Sure. And the entire episode, so we follow patients, I would do 2 weeks, 6 weeks, 12 weeks, and the physical therapy for a total knee might run 10, 12 weeks. So that 90 days captures the full episode of care. And so to just do day of surgery or something different, you might not get the savings that you would get if we organized that entire 90 days of clinical care for the patient. Anybody, other comments on prospective versus?
Yeah, I think one other comment, if I may, and that is that with a prospective bundle, and we see this very consistently, the forced downstream contracting exercise that comes with prospective bundles is unique, and you will not get that dynamic in a retrospective bundle. So the fact that, Dr. Lucy, you're going to the anesthesiologist, you're going to the surgery center, and not only crafting agreements, but service level expectations, that's an added benefit that we don't per se see in the retrospective space. So that's something that not every group has the capability and the infrastructure to do today, but I certainly see value in that as a pair.
Good. Thank you. One here.
In terms of the 90-day bundle, I think the problem that we were all having before is that the surgeon was sort of the captain of the ship in the operating room. But clearly that wasn't happening for the 90 days when 96% or 94% of the steering was occurring. The model was everybody was trying to just pull as much money out of the payers as they could. I mean, we kind of touched on it, but 21 days is,
Right.
Clearly, the business model was let's just pull as much money out of the payers as we can, because it's a third-party payer system and nobody was watching.
Right.
And so, the surgeon is the most appropriate person to be in charge of that, because they're in charge of the patient's health.
Yeah. It's good. Frank?
The other comment I would make is drilling the education. Case managers and BPCI is drilling the patient. If you have a problem, call us. Do not go to the emergency. If you go up in any ER, it's $1,000 right off the bat. And just getting the patients to call you, because once they 90% of the questions they ask, we can take care of, we bring them to the office, keep them out of the hospital. And they get, you go to the hospital, it's a 5-hour wait to the ER, and they look at you, and then they call us anyway. It's not like they do anything. So, with the case management and educating the patients better and making sure they understand what we want, it's been a big
Yeah. And we're going to talk about some of those techniques tomorrow. Everybody good? All right. Questions are going to get harder. Might need a drink, some water. All right. Still here. So in layman's terms, or in orthopedic terms, very basic, why is it so hard for you to tell us how much you spend on a 90-day episode of care historically? If the member is paying you a premium and you're paying for their care all these years for total knee stuff, and then I come and say, how much are you spending for 90 days? Because I want to help you save money and take better care of your patient. what's the struggle with telling me your 90-day spend or calculating, or what barriers have we had there? We can start
So I'll
wherever,
probably
whoever
answer
wants
this
to
a
jump
little
in on
differently.
that one.
I don't think we have that problem. Maybe
Oh.
some we don't, but I think we built, the capability into our claim system to administer the bundle. So part of that was creating the definition of, what that means, and so basically it's relatively easy.
Wow. Sean Strong from Aetna just said it was relatively easy. Okay.
The Blue Cross guy's getting ready to agree with the Aetna guy, but I would say we don't have a problem identifying every piece and part and having that data. And it's the key is either you build something yourself or you partner with a vendor that can provide those analytics for you. But we are able to.
All right. We're gonna have
Now,
to
whether
keep-
we
we're
wanted
gonna-
to share
we're gonna
that
have
in the past before it was a bundle, that might be another
We're
question.
going to have to keep it real, Jake. First time we met, we didn't like each other very much. Because I asked you that question and you didn't know the answer, and I thought you were being dishonest. And you weren't being dishonest, you just didn't know. So my question is, if you go back, like now, you guys got it going on. But if you go back to 2015, what was the problem?
I think it was the data, and back then that was early for me. So I don't think we had a good handle on what's in, how to build that bundle, and our perspectives on on actually measure may have been different.
Okay,
I mean, I think that's fair to say.
fair.
I'm going to go 3 for 3 here and say yes.
Dodge.
I
Dodging.
I think the biggest challenge is exactly what we just said about what's defined in that, so we can include those appropriate costs, because many folks have different interpretations what a bundle really looks like. So I think all about including what services you want, but we can absolutely tell you what the costs are.
Okay, so Joe, if I told you that I wanted to know your 2017 average spend in Greensboro for a total knee or a total hip, including the inpatient facility fee, the surgeon, the anesthesiologist, home health, outpatient PT, DME, you could give me a number.
I can go back to my laptop right now and tell you.
Excellent.
Absolutely.
Okay.
Yep.
And how long has that capability been there on your laptop? A year, 3 years?
I would say
Today?
mid-18 is the first time I saw those.
Sorry?
Mid of 18.
Mid of 18. Okay, all right.
So MedCost is fairly new in this space, and we have developed some algorithms, but I would agree with some of the comments about what's included, what should be included, the timing of claims filing, things of that nature that have impact on what I would call the accuracy or the validity of the whole picture, and knowing that you have all the whole picture when you want to calculate what that savings is
Okay.
or spend.
Jordan?
Agreed. Yeah, I think it's calculating what's in, calculating what's out. We can load an episode definition. We can spit out real time what the run rate is, or what the cost rate is for a given period of time. It's tweaking and modifying that algorithm and determining from an actuarial perspective what do we want included and what are the unintended consequences when you remove one piece and then things fall out. So it's a fairly complicated dialogue when you think about what really should be in, but the process and the mechanics, I agree with the folks down here. It's pretty straightforward.
Okay. It hasn't been that straightforward from our side, because we've asked a lot and we don't get quick answers back, and I realize it's a rapidly changing industry and you're getting tools to do it. But not to pick on Jake, because Jake's actually one of our heroes, because we're doing great with Blue Cross and they're doing great work in the state and they're leading the way. But back in 2015, we asked for a 90-day spend. They gave it to us. We choked. We thought they were dishonest and whatever, because we took the EOBs from the patients and we said, can you give us your EOBs? And we laid them on the table and said, here's what you're spending. And they looked at it and said, oh, well, that's not what we got. And so we pushed through that. So that's real credit to us and to Jake and North Carolina Blue Cross, because it really was contentious, because we asked, they didn't know. I said, oh, they're just being dishonest. And they actually weren't. They didn't know. Then they came back with a number, their best guess, and it was different than what the EOB said, but they recognized we need to get to the bottom of this. And so there was a lot of push and pull and transparency, which ultimately we got to an understanding. We figured it out together, and we did business. So it's good to know that we're progressing into where, and I will say, Sean, you've been great. We ask you how much a 90-day spend is for this, and he spits back my numbers. They look like the EOBs, and so, there's definitely progress. But that's where the negotiation starts, right? We have to know what the spend was if we're going to save you money, and we're going to try to figure out a business model that's different. This next question is not any easier. So if we just made up a number of what your episode spend was in 2016-17, what kind of percentage discount are you looking for? I didn't ask you a dollar amount. I just said, just give me within 5 percentage points what would be a win for your company to come to Greensboro, North Carolina, or Raleigh, North Carolina, or Houston, Texas, and if it was $100,000 90-day spend would be going to $70,000 for a 30% discount. Would that be it, or would it be 25? You know, what percentage are you looking for? Just to give us a general. We're not gonna hold you to it. We might not, but just give us a general answer if you're willing. Nobody wants to know. Jake's already done it, so he gets a pass.
I'm sitting in the middle. It's not fair. I can tell you we really haven't built the program to say from an ROI standpoint we need to be hitting this number. What I can tell you, and in different conferences I've shared, we're trending between 20 and 25% savings. And there's some things that are hard for us to calculate or add in or take out. We've got some admin that it's hard to actually say, well, you need to back a little bit off of that because it's costing us to do the bundles. But I would say what we're looking for is progression. When we grow the program, the trend each year has looked to be about 5% better, so to speak. But we've not been real good with the data until the last 2 years. So I would say, again, 20 to 25%. If you're asking me, what do we have to do the programs? I don't have an answer there because that's not the way we're looking at it. We're also looking at what's making sense for the quality of care for our members.
Yeah, sure.
So it's the cost and the quality.
So you've got investment costs that we don't see.
Absolutely.
And so a certain amount of volume will help pay that.
And we talked with a couple of folks earlier today, and when you're talking about fee-for-service versus a bundle, well, should we be talking about volume? Well, in order to make the episodes of care work for us, you actually do need to run volume through it. I mean, that's the way those things really pay for us.
Sure.
And for
Anybody else willing to give an answer?
you've got to say.
Well, if you get 20 to 25, I've got to get more than that, right? You know, I think very similar answer. I mean, something like 20 to 30%, I think is what we're shooting for on the joint.
Does that mean we get 20 to 30% more also? Like on the site? We'll come back to that. It's a good answer. It's a fair answer. They cost you guys a lot to develop the systems. I'm not demeaning that at all. Anybody else? What kind of percentage, anybody willing to share what a percentage would be a win? I mean, it's not 5 to 10%. What is it, 20, 25? Is that a go in general? No one's going to hold you to anything. We don't have contracts for them, nothing. Just any comments? All right, so if anybody else disagrees with that. So doctors, administrators, we have a general 20, 25, maybe 30% charge. And it's going to take a lot of work, to get there. You have to put the systems in place, just like we have to put the systems in place, et cetera. Okay. Thoughts on steerage for your members. So if you get a situation where you've got some good joint surgeons doing bundles that's saving you 20 to 30%, how are you getting them to the doctors that are doing that? Let's start with Jake, because he's got some experience with us. But then even the ones that don't have bundles or don't have a bundle, but you're about to have one, Wanda, I want to hear your thoughts as well.
So currently, we have no product-specific member cost share reduction to participate in the bundles. But what we have done, and we really started a pretty big marketing program back in the spring of last year. And we've got different channels, but we're marketing to our providers, our members, our ASO groups, who we're partnering with. So we've got websites that are, and we send emails to members, prospective, by looking at their claims. We do DNA, we call it DNA, but it's our analytics team analysis on their claims and said, hey, this might be a member that's going to need a knee in the next year or so. So we then say, hey, if you want to go to a high quality, low cost provider that we're partnering with, it takes you to their website. It's got a contact name or contact number, and then that sort of starts the process. If you're a group member today and we have our online portal, you may actually get a tile on the portal that says, hey, need or hip replacement, click on the tile, and it takes you to some of the other spots. So it's about communication. I think the next level for us will be product design and including that in our products, but that sort of has a long window of time sometimes to get those built in. But I think that's definitely where it's going. But the marketing material, and I share that sometimes in our conferences, it's pretty good stuff.
Yeah, so I mean, this is one of the things that we're working on. We're trying to sort of figure out what works. I mean, I think if you sort of think about the levers that we have, one would be, the member. How do we, encourage member? The most obvious one is plan design, which I mentioned before. We'd like to be able to say you have lower copays, or we'll waive the copay or deductible, or whatever. That's something we're looking at. The other way is like looking at where the PCPs are sending their members to which specialists, right? So that's obviously most people just ask their PCP and go with that. We're looking at that. The difficulty we run into a lot with that is, that PCP is part of this ACO, this total health system, and they're not going to encourage somebody to go to this independent specialist. But in some markets, some areas, that might be a very, very effective way to do it. And then, again, the member, trying to communicate through plan sponsors. The big employers in the area that are insureds, like they might be willing to promote it to their members as part of their open enrollment, part of their benefit newsletters, that sort of thing. But I wouldn't say that we're really crafted.
I want to hear from Jordan and Wanda, and then I want Frederick to answer last, because he's got a very unique perspective with representing privately insured companies.
So we've considered several opportunities that might exist in partnering with. We've talked to Lisa and the care management and trying to partner our care management teams when we have opportunities to work directly with our employees. And then just this week, Frederick and I had a conversation yesterday about what we might do partnering with his employer groups to find, whether it be benefit plan designs or rebates or debit card or all of the available compliance type wellness incentives that we might couple with this program that could incentivize employees to use a program that could have great outcomes for them in a different way. It's a different kind of consumerism. We talked about it yesterday, and it is about education and communication. And so we equally are trying to put together some really nice marketing material that we could just launch for our employer groups, and then they can put on their intranet website and things of that nature, so that we can bring high visibility to it as it becomes very real.
Jordan, any thoughts?
Yeah, I'll
steerage.
try to add a couple new ones that haven't been mentioned. The first is, so in the payer world, we kind of think about, we call it hard steerage and soft steerage, right? Hard steerage is the more traditional. We're going to change the member's benefit design. We're going to make sure that the member has a very intentional out-of-pocket cost share differential to go to one place versus the other. There's limitations on that. So one of those limitations is when you're having a joint replacement, whether it's outpatient or inpatient, almost every member is going to hit their out-of-pocket cap. So from an out-of-pocket cash outlay perspective, nominal impact to the patient. So something we have to take in mind. We've implemented new care management protocols and actually requiring prior authorization for services that are done inpatient that actually could clinically be done on an outpatient basis. So the payers are getting more aggressive in taking tactics to really help encourage at the member level and at the rendering provider level migration and incentives to move patients in that direction. And then the third is transparency. So I think the gentleman from the Blues mentioned some website information. We do try to use consumer purchasing tools to help drive members to the most cost-effective providers. I think those tools will continue to evolve and be more prominent. But we're also taking steps with our PCPs, particularly those who are now taking risk on a total cost of care basis, to help not only educate them about the most cost-effective specialists to use, but also beginning to force the other specialists in the market to follow suit in terms of their cost and their quality position. So kind of benchmarking based on some of the highest performers is another means by which we can kind of drive down performance down to a much higher standard than what we're otherwise receiving today. The cost variability is still astronomical in any given market.
Good. Frederick, tell me about, Frederick represents a bunch of self-insurance companies, so they're spending their money on healthcare, and so Frederick helps them with some of these steerage issues, so give us a couple thoughts there.
You know, we've primarily been involved in, you know, expensive surgeries. We're not talking about the mundane day-to-day healthcare issues. And so the stance we've taken is they need plan design to begin with. And then they've got the transparency piece is extremely important. And they've got to incentivize the employee. Because human nature being what it is, the employee's going to go, well, what's in it for me? I've got a choice between getting this surgery at Mission in Asheville, or I can go to Greensboro and get it. And employees are simply not going to make that change so they can save their employer money. I mean, we may all want employees that do that, but we don't have employees that generally going to do that. And so what we've said is the surgery's got to be free to the employee. And so we've got employers that are adopting that kind of policy, that if they want steerage, they want influence for an employee to consider the economics of going to one high-quality surgery center versus another surgery center that's high quality, you're going to have to put some money in the employee's pocket. And so to do that, we're saying waive the deductible, waive the co-insurance, and even consider giving them a % of the net savings. And if you can move the needle on the employees economically, then you will begin to get people that will take a good hard look at what I call domestic travel to get an ASC.
Yeah, so we're not a fan of medical tourism where you fly somewhere, have your surgery, come back, and then you're not with your surgeon for that 90-day episode. So we've coined the term here anyway, corporate bundles, and so we've offered a corporate bundle to Frederick's groups to come here, and it includes actually a night stay pre-op at the Proximity Hotel.
Yeah, and we've been involved in exploring these other options internationally. We've gone with Willis Towers Watson and looked at facilities. We've been lots of different places, but we recognize that the value is getting it done close by. The proximity and access is very important to the employee. And so, but if you can blend the economics, the quality, and the accessibility together, then you got a winner.
Any other ideas, even from the audience, whether you're a physician in the industry or as a person that's had a parent that's had a joint replacement, how else can the patient win in this environment? What other things could we do where the patient actually wins?
Just one comment on the steerage. I just caution you going by the primary care provider, particularly in our region. Many of the primary care providers are hospital employees, and those hospital employees are heavily incented
Yeah.
and monitor and reporting on whether their referrals go to hospital employee or burden surgery versus outside their hospital employee. So frequently, hospital employee surgeries may not be highest quality, lowest quality. They may be here, may not be. But there's a lot of steerage going on within hospital employee networks to keep all services within that network. So that may not be a referral based on high quality, low cost.
They would probably typically be higher cost because they'd be at the inpatient facility who owns them. One of the things we do for the patient, or one of the things that is part of the design of the bundle, is that once they settle up at the front with their deductibles, there's no bills or copays from any of these other downstream providers. So they don't get a surgeon bill and an anesthesia bill and a DME bill or whatever. It's all one bill up front, no copays at therapy. So that's one way we've created a win. We've talked about other ways. Any other thoughts on how the patient can win? Stefan.
I mean, I'm listening to this conversation about bundles, and in what business do you get a 30% discount and have the person that takes the bundle take all the risk, which is what we will do as surgeons. So I think the biggest value to the patient is when we are on the hook for the complication, I don't care how good of a surgeon you are, you'll try just a little bit harder to not have a complication.
Mm-hmm.
Whether it's a dislocation, whether it's a hematoma, whether it's whatever it is. I mean, I think I'm pretty good, but I have complications. But I can tell you, if I have a bundle and I'm responsible for that ER visit and that readmission because I'm paid out of my pocket. I'm just going to check that in one more time, maybe get one more X-ray, make sure it's absolutely perfect. That's the value to the patient. And I'm sure you will show that your quality is way above the norm when it's not enough.
We will tomorrow. Thanks. Yeah, and that's an inherent win within the bundle, that because you're at risk, you're going to pay attention, not just gloves on, gloves off, but the entire 90 days. Frank?
The other value the patients are getting out of this is they're essentially getting a concierge service. They have their case manager that is monitoring every single aspect of their care, starting the day they're signed up for it, through surgery, through 90 days after. A direct conduit to the physician, they're getting much more hands-on care than they're doing in another setting.
Yeah.
So they're getting a lot more value out of that, too, compared to what we're getting.
No doubt. We've probably each year had one patient go through a knee or a hip the old way and one the new way. And those patients always go, whew, you guys have made this thing better. You know, they just really enjoyed it. Okay, payers. So the drinks and hors d'oeuvres tonight are a mixer between the payers and the providers. I mean, one of the reasons we're doing this is because we want our doctors spread out from all over the country and our payers from all over the country to meet one another and have this kind of conversation and start the conversation that will end up into bundle payments in your community. So that's what we're doing. So as we're going though, if you happen to shake hands with someone over a glass of wine and say, yes, here's my 90-day spend, here's my 25% discount, let's do it. How long would it take you until that doctor could actually do a bundle? Contracting, whatever kind of claims adjudication software has to be done in your area for that bundle, whatever system has to be built, their attorneys, some kind of informatics platform, all that kind of stuff. So just give us an estimate, in your opinion, of how long it would take from the time we shake hands tonight to the time the doctor does the first bundle.
I mean, I would think like world record fast would be like 3 months, probably 3 to 6 is more typical.
Sean, you're going to have a lot of shaking hands tonight.
I've got caveats. Are you already doing a bundle with anyone else?
No.
Do you have it? Someone
No,
like Valere?
your Grant Zarzor from Mobile, Alabama doesn't have a bundle yet, but you and he shake hands tonight.
Is this an
No.
episode
BPCI.
that we already
Yeah, they could
administer
have
with
a
someone else?
BPCI, like they know what a bundle is and all that, but no commercial bundles in an ASC. No prospective 90-day commercial bundles in an ASC.
I say you're closer to 6 to 9 months.
6 to 9 months, okay. Joe?
They have someone like us to help get through.
Yeah, maybe sooner. Maybe.
4 to 6 months.
Deal.
You're kind. Yeah. Man, we were trying to get Grant a bundle.
Yeah,
Joe, what do you think?
No, I would agree. I think 6 to 9 months from implementation to contract signature and going live seems realistic to me.
And why so long? Man, that's a long time. Kinda, long time.
Many levels of complexity, I'm sure, within each of our organizations to put something in place.
Okay.
Just
Wanda?
I'm sorry, I can't argue. It's 6 to 9 months, and I think experience kind of shows that. So.
How long ago did we shake hands?
I think Vicki reminded me it might have been a year ago. So.
Okay.
But we've learned so much. We are so much smarter today than we were a year
Yeah.
ago.
Oh, I love it. Yeah. But we agreed to terms. We agreed to a rate 9 to 12 months ago, right? Still not. We're still not. Operationally, there's challenges. Contractually, there's really not. Yeah. Right. And we still like each other.
My last one, 6 to 9 months for United. One other disclaimer or caveat, and that is that every state has some different regulatory glitches and hurdles and nuances, and some are quicker to turn than others. And that's been one of the largest items that's protracted our discussion. So individual states may vary.
Got it. Good answers. Pretty predictable answers. Jake, since there's how many bundles do you have in North Carolina?
We've got 8 contracts right now, but so knees, hips, shoulders.
Live.
Live. Yeah.
Okay. So North Carolina is a hotbed for bundles. It really is. And so North Carolina Blue Cross has led the way. So that's a lot for a payer.
And it's exploding with the number of requests we're getting. Too.
Yeah.
So I think it'll grow.
So you may have, well, no, Sean gave the shortest answer. So Sean is going to be a popular guy later, but after Sean,
The biggest discount.
He made that up.
So Dr. Lucy,
Stefan,
we've been at this for 6 months with your help, and we haven't seen a contract yet. So 6 to 9 months, I think, is overstated.
yeah, I think part of that is that the industry is changing. 3 years ago, they couldn't tell me their 90-day spend. Now they can tell like that. So, I mean, it's rapidly changing. And so hopefully the next year the answers will be 3 to 6 months for everybody or 3 months for everybody or something like that. So it's definitely still new territory. No doubt about that. Does anybody else but Jake have a 90-day, well, and Sean, a 90-day prospective bundle anywhere in the country? A 90-day prospective? 1, 2, 10? 38 in joints?
Lower extremity joints.
90-day prospective.
Yes.
Ah. Didn't know that. That's good. And would you agree with, so you said 6 to 9 months?
Took longer.
Longer.
Took longer.
Okay, fair enough. Other questions? Yes?
Jake mentioned there's a lot of interest and requests coming in. How do you prioritize them? How do you accelerate the process? Where's the holdup?
Well, so that's what makes part of it 6 to 9 months. So I think in a vacuum, it's not 6 to 9 months, but we have so many other things going on. So when we talked about the priorities with our move to value in the system, the Blue Premier product that we've rolled out across the state, that's been the top priority. I'm not staffed. We're running this with different pieces and parts of different areas of the business. So it depends on who you're working with when you talk about that timeline. So it's all about priorities. And if I had a group and all we were doing was bundles, we could go faster because we've built the infrastructure. If you've got the infrastructure in place, you could go faster. But it's hard to do that, even the bigger payers, if you're not structured that way. Did that answer your question?
Yes, sir.
Are the bundles set up to be multi-year with no contemplation of how the rates are going to be? Because you can't keep getting 30% every year and maintain a sustainable market.
So the question was, were the contracts set up to be consistent year after year, or is there a 1 year later you're going to be asking for another 30%?
So, I mean, generally, the way our contract, it would specify a dollar amount, say whatever, $30,000, and that's what would be in the contract. And we wouldn't anticipate that, it's not like the BPCI program where your average averages in and continually goes down. My expectation is we would, keep that rate until at some point in the future, you're going to come in with some kind of an increase.
Both parties need to make a reasonable return, but I do know corporate America always wants, once you see the savings, this inherent drive to lower the market.
And I would say we've got a case example with Dr. Lucy with what we just did with shoulders. So we just brand new episode for us. We're both new to it. So I think just did a 1 year, and we're going to look at it and say on both sides, we're going to look at what the data looks like, figure out if that rate made sense. If you lock in for a bunch of years, you could hit exactly what you're talking about. And that's the thing about bundles.
This is more directed towards Jake and Blue Cross because we're so dominated by Michigan. So you've got, sounds like you got a good thing going on here in North Carolina, but the Blues is different in every state. And do you guys have a national plan for this in place, or is there a plan to have a national plan in place?
That's a good question. We are working. All of us have worked with the association on things to standardize what those bundle programs are going to look like. But I think the hurdles we have is the fact that we're all separate. So I would say we don't necessarily have a countrywide plan. I know the association's talking about bundles. They have things that we have to, because there's rules and regulations around that. So that's just what makes it tough, I believe.
But what's happening on May 2nd? Where are you and I going to be?
The summit.
Yeah. So we actually are doing a co-speaking engagement at the Blues National Summit on the story. So hopefully hopefully your person's there, you know, and they pay attention and they start to ask questions. That's why we're going. Please do and let us know, because we'll track them down, or I'll track them down. All right, anyone else on the year after year potential reduction? Yeah, that's a non-starter in Greensboro, North Carolina, I can tell you. Because if I'm going to keep Dr. Rowan from retiring, I'm going to have to keep paying him. And if I pay him any less, he's going to go play golf or chase grandchildren. And he's a good surgeon, so we need the money to keep him in the game. Okay, I'm going to flip it a little bit and ask the docs a few questions as well, because the payer says I gave them questions and said, well, I have a question. So, okay, what is it? So there's a couple of really good questions, but for the docs, on the clinical side, what is the greatest impediment to you doing outpatient total joints? Any of the surgeons just care to share, what is the greatest impediment to you doing, Dr. Chiavetta?
Yeah, I mean, it's just getting the whole system set up, establishing physical therapists to be there at the outpatient service. You know, working with the anesthesiologists too, because a lot of them are kind of fearful of doing some sort of procedure. It's a fairly major procedure in an outpatient setting. And then also, another big challenge is making sure these big patients have a good support system at home, because that's a huge part of it. Is that you just can't send these people home later on that afternoon to an empty house for them to get taken care of. So, I mean, those seem to be the biggest hurdles.
That's good. Those are good. Julia?
I just want to share an answer. Maybe you do the same thing at Delta, but I was with another orthopedic practice years ago talking about bundles, and one of the things that they do is if you live alone and you have a dog, for example, they pay for the dog or have a dog walker come to, you know, reduce that risk, because many people walk the dog and they fall, and it causes a complication. So I was shocked with that, because I hadn't thought that through to that minutia, but it makes a ton of sense.
It does. The Delta Dog Walking Service. Doctors, any other, what are your greatest impediments to being open to the side of service shift occurring?
I think there's a difference between same-day discharge and one-night stay. And I think sending the patient home 4 hours after a knee or hip replacement gives me a little bit of an ulcer. Worry about it. So if there is a good system in place where the nurse can meet them at the house that night, tuck them in and make sure, that would significantly reduce my anxiety of a same-day discharge versus a one-night stay.
That's fair. And state to state. So here we have overnight stay facilities, you know, the Overflow Hotel here or whatever, but some states you can't keep them overnight. I think, Grant, Alabama can't keep them overnight, so got to set up a good, solid program with all of that. Yes, sir.
Along the same lines, we've been doing outpatient joints for about 5 years now, and we do a good volume, but we have a large rural population when it comes in to see us. Many of our patients drive 2 and 3 hours, and there are some issues with putting people in an alternate accommodation at a hotel. It's like you're trying to have a cheap hospital or something. So in our situation, one of the things that would be a slam dunk for us would be, I'm anxious to see how you use this hotel. Because we have a building next to us that we repurposed and turned into a hotel. We've been doing joints for 5 years, and I think in that whole 5 years, we maybe sent 1 patient to the hospital for 2 for pain control, and we've never had a patient stay overnight.
That's good. There are some docs in the Midwest, I can't remember exactly where they were in a CON state where they didn't have overnight facilities like Alabama. And so they actually, across the street, bought some land and tore down a building and built care suites. So they're literally discharged, and then they go have their night at the care suite, which is like a condominium, and the physicians owned it, and you know, whatever. So it's just a different way to.
The building is right next door, and they go out one door and into another.
Good.
And
Yeah.
it's in St. Paul.
Okay.
And just one other thing about the concern about having someone tuck them in. We also have physical therapy, so we have within the next day,
we have in-home therapists go and see the patient, which is, they know wounds, they know how the patient's doing, so they don't get tucked in at night, but they do get seen within a day or so at home. And those therapists will text us, send us pictures. There's a experience, they take care of most things themselves. It's very nice. Patients like that too.
So, but the question is, if you control the bundle, you can cover that cost.
No doubt.
If you don't control the bundle, then who pays for it? Because most payers do not pay for home health if it's non-Medicare.
It's not billable by insurance. They're not going to pay for it.
How do you convince a therapist to go to their house if they don't get paid?
Well,
He's paying.
We own the therapy. We own the therapy, and then they'll eventually, a lot of them just come back to our outpatient facility.
Yeah.
It's not
So we
home health,
can-
it's outpatient.
Outpatient visits are there.
And I think, and in some states, you can send your therapist that you employ to their home, and you can just bill it as a therapy visit and collect. Right. Yeah. Yeah. Grant.
I think the biggest barrier for us is the administrative aspect. To be able to make sure that the claim gets billed correctly, or we don't double bill, the insurance company doesn't get a claim from the physical therapy provider because we forgot to tell them that you can't send them a bill anymore, we're gonna pay you directly. If you don't have someone to manage that slide you show with all the different relationships, so if you don't have someone to manage all those, then we're gonna mess something up and ruin the relationship with the payer. And maybe we started with a bundle, but it's not gonna last long because it was too hard for us to make happen. So if you don't have a Valere to partner with or someone like y'all, for us, there's no way we could consider it.
And Don is not for hire.
Negotiable.
Any other impediments to the site of service shift from the surgeon perspective?
I think community perception, that's something we have to overcome in the beginning here and anywhere, is that a lot of these people feel that, oh my God, this is such a huge operation, I need to be in the hospital for a day or two or longer. You have to educate, and that's one of the biggest things with education on this, that it is safe to do it on an outpatient basis, and you're gonna have a better experience if you do it that way. So once we here got rid of that community perception, it's a huge win. Patients so love it.
Yeah.
A lot of communities the same way have to overcome that fear. So overcome the fear of the patient.
Yeah, it's good. It's good feedback, and I think it's good feedback for the payers to hear the doctors say that, because all of the comments were patient related. It was care for the patient. Sending them home makes me nervous, or whatever. We send our own therapist out to see them, or whatever. So they didn't say they couldn't do the surgery. It's the care of the patient in the postoperative situation. Instead of keeping them in a hospital a couple days, you got to figure out what to do with them to make sure it's safe and they get good care. So that's good. And then the administrative one, that's those departments that are in the hospital. You take those away, you need some administrative help. So, making sure you have patient care pathways in place to give them that concierge level care. And then you have some kind of administrative support, some system around the patient that allows you to do it. So a question from the payer to the doctors, one of the payers to the doctors, how do we feel about shifting the site of service only for a small portion of patients, the real healthy, commercially insured ones, but not the others? Now, we've progressed far beyond that, but that's where you start, right? Cherry picking. You take your healthy ones with really good insurance, you walk them across the street, and you do it over there. So what about just shifting the site of service for the healthy ones and not the rest? Anybody have any angst over that?
Really, with the commercial insurance, of course, are all, very few of them are Medicare age, so they're all young and therefore more healthy than a Medicare population. Most of those are good for outpatient surgery. And I think we're also find that a good percentage of Medicare patients will be good for outpatient surgery as well.
No doubt.
Yeah.
Stephen?
So when we talk to the payers, we don't talk about an outpatient bundle, we just talk about a bundle, and then we have a relationship with a hospital as well as a surgery center. And then, because we want to decide whether a patient should go to the hospital or the surgery center. So if we can do all comers, and then just risk stratify and do the more risky patients in the hospital.
Are you doing one price fits all, or are you doing a couple different prices, one healthy bundle price and one not so healthy bundle price, or one outpatient, one inpatient?
Well, if I had an offer for a bundle, I could answer that question.
All right, who wants the first drink with Dr. Kreutzer? Jordan just volunteered. one price, a blended rate?
And they set the target, and we said, can we see the data? They said, no, it's the project. What are you paying? We can't tell you, that's confidential. And then they said, you'll have all the incentives to shift it.
Yeah.
And we said, we didn't have the experience of going outpatient. We said, how about just an outpatient bundle? They said, no. They were shifting the risk to us.
Mhm.
They were asking us to reinsure without data. And I said, how can you do that?
Right.
Where's the actual?
Yeah. He might not be having a drink with you tonight, I'm not sure. So what we did with Blue Cross was we negotiated our first bundle. We cherry picked. We took the real healthy ones. And then everybody did really, really well. And they said, well, this is great. How do we do more? So then we decided, okay, we'll do a second tier. So we type them 1, 2, and 3, real healthy, not so healthy, and don't do them in the outpatient surgical center. And so we got a second rate because we're taking more risk. It's requiring more case management, more concierge level care. We agreed to that, and then we just blended the two rates together. So that's kind of our history of, so now we don't just cherry pick. We have cherry pick, and then we have, beyond that. My personal prediction is that we're gonna do way more than 50% of total joints in outpatient surgical center. I think SG2 is wrong, and I think it's gonna be closer to 80%. And here's why. Keep your money in your pocket. I can do a total knee in the garden. That's not the problem. You can do a total knee in this room. The problem is what happens, I would never do a total knee in the garden, by the way. Unless it was a sterile garden. The problem is not where you do the venue for surgery. We could do it at Cone Hospital, the Surgical Center of Greensboro. You're not gonna have, I have not had a patient stay in the hospital longer than 2 days in a long time. The problems occur when the patient gets a DVT on day 10, or an infection on day 24, or whatever it is, right? Or AFib, or something like that. And so they tend to have their surgery, get discharged on day 1 or 2, leave, the DRG and everything's been paid for, and then 3.5% will bounce back somewhere. So doesn't it make good financial sense to keep your money in your pocket and get the cheapest side of service up front, so that if that 3.5% of the patients come back, you've got money to spend on the complication? Why blow it on the index operation day? So my prediction is people are going to start doing some good economics and say, hey, we want these bundles, we want them done in a surgical center or a one-night stay in the inpatient facility, get them the heck out, insurance or the infection rates go down, and then we save more money, and we'll keep that for the 3.5% that have readmissions. The role of the payer in controlling costs. So doctors, what do you think their role is in helping us control costs? How can they assist us in costs? We know they need to create systems, but how do they empower us to do this? I know bundle contracts. Okay, I just got to say, get us some bundle contracts. Anything else? What can they do? How can they help? Come on, we're smart guys. We can figure it out. Incentivize for quality. So quality programs, similar to kind of what we have. And we have a metric-based bonus program. Okay. Getting bundle contracts. Incentivizing the patient.
They can participate in better outcomes and savings.
Okay.
Steering the patient in a different direction.
Okay. Steerage.
I don't know if that's really their job. I think that's kind of our task, a little more than their task.
I think to help the patient understand they're probably the primary director of their, not surgeon or internist or anything. They are the ones that are going to turn it over their person.
Okay. So putting it on the patient to put their health. Yep. Okay. What about, as I was listening to y'all talk about defining the episode of care, have you talked to orthopedic surgeons that do joint replacements to help you define your care? I mean, like you're trying to figure out what should be included. Do you ask us or our case managers? I'm asking because, and you might in Winston-Salem, Wanda, you may, or in Raleigh, you might, Jake, or in Colorado, you might, Jordan. But are y'all working with us to help define? Because we know what they need because we've been writing those prescriptions for a lot of years.
Yeah, I think when we talk about standardizing a system, and that's a technology system, to make it work and repeatable and be efficient, we like to start from a base that today we're using Prometheus. So that's the bundle definition, that's the how it works, and that's what's in and what's out. Because when we process those claims, that technology will do it for you. It tells you. But that doesn't mean that there's going to be alternative payment models that are going to come from the provider. We're designing them with the providers. Bundle payments, one of these. So I'm not saying that we won't veer off of Prometheus definitions, but it makes it a little more harder to make those timelines when we do that. But if it makes sense, I mean, we should be having those discussions.
Any of you working with clinicians, actual orthopedic surgeons for orthopedic bundles and GYN surgeons for GYN bundles? And
so we've not really taken it to that level. We are talking to our internal medical directors, and they're assigning us folks to work with those.
Yeah, so just a word on your internal medical directors, because we do peer-to-peers all the time. They're not orthopedic surgeons, and they don't know what needs to be included in a bundle. So my advice, you got some really sharp people in the room who made the effort to come to Greensboro and sit here and listen, like, have a drink, exchange information, and use these people as resources to help you define your bundle. I know it's not that simple, but at least starts with a relationship where you could call and say, hey, should we include the walker? Should we include, 38 visits are outpatient PT or 18 visits of outpatient PT? I mean, and have a conversation, and you could probably, learn and corroborate to get a good program. You were going to say something, weren't you? Go ahead.
We need to balance, right? We need to strive for some degree of consistency, right? So you got Medicare with BPCI. It's the biggest payer in the United States, right? We want to make sure that as we define a bundle, it's not different, so dramatically different from Medicare, different from Blue, different from Aetna, that you all, the surgeons, are struggling to figure out, well, what does my patient's ID card say, so I know how to treat them and what's in, what's out. So I think your point's really well taken. I think your feedback from the ground up as a surgeon is extremely important that we take that into account. But we also want to make sure that we have some degree of continuity across payers, so that you guys aren't pulling your hair out trying to figure out how to treat United versus Aetna versus Blue.
That's fair. That's good. Any other questions for our payers? Reggie.
Yes, kind of goes back to your first set of questions. Just curious, more on the panel. The trend is obviously well underway with value-based healthcare. And when you break it down into its pieces, there are a lot of different, say, call them demographics leading the charge. And it's always impressed me about here is it's physician-led. I feel that's very important to ultimately get to a consistent quality outcome. You have a prediction for us in terms of as that market evolves and value-based healthcare comes into more of the norm, where physicians follow the spectrum of the bundles?
I'll take that.
Please.
We're picking our partners right now, and we're very deliberately bundling with the specialists who are on the cutting edge and who are driving the change and the reform and really accelerating this adoption of things like migration into ASCs. I would say 2, 3, 4 years down the road, we're going to see ourselves and other payers making pretty hard choices about who's in our network. And that's, that's happened before, right? We've seen narrowing, we've seen those kinds of things. But ultimately, if the cost disparities continue, I mean, I know markets in the country that have $100,000 joint replacements. I'm not looking for a 20% reduction. So we're going to be seeing some very hard choices be forced upon us, not only as payers, but as the fiduciaries of self-funded customers to pick our partners. So long as we're working together and we're working in this right direction, I think we're on the right track. So I see the physicians and the surgeons in particular really helping lead that charge.
Yeah, I mean, the one thing I would say that I think the missing piece now that I think with as much sort of venture capital that's flowing into our space, it's just a matter of time, is like as a patient or consumer, there's really not much information available about, who's a good surgeon, who's a bad surgeon, how much they cost. And I think, one thing we probably all love about Amazon is not just you don't have to go to the store, but you can read reviews and things like that. I think it's just a matter of time before there's a robust consumer-based tool that comes out like that has, clinical outcomes, patient satisfaction, and I think that's going to be probably the biggest thing to shape sort of the value-based story. And really, all physicians of all types are going to have to produce positive outcomes if they want to maintain their practice.
So I have a question. Oh, so there was a question over here?
No, I just say that I think the onus is going to be on us, not the metrics. The metrics are cooked. I get notification every week. You want to buy some online website improvement profile to drive marketing, because you introduce so many of these non-clinical variables. But if you recognize that my patients are coming back for readmission, they have long-term outcomes, and it's cost effective, you and I are then going to establish what the true profile is. Right now, the Medicare attempt, if you're the fix-it guy in your community, you take the train wrecks, your complication rate is higher than the people who cherry pick. And that's what the consumer's clicking on. I get punished for fixing the train wrecks. And so you're essentially encouraging through these ill-informed informations to the layperson who the best surgeon is. So I really think it's us that will determine the appropriate metrics to drive patients or steer the.
Yeah, I mean, I think a big part of it, these outcomes, that I'm sort of talking about, are from the patient's perspective that nobody's really captured today. And I think that's
Good clinical data, though. Good clinical data. Readmissions,
but also from
complications.
What's
Patients.
your pain level like?
Right.
Can you walk better than you could walk before? That sort of thing.
Right.
Like it or not, I'm convinced that's just a matter of time. It's
Yeah.
probably not 5 years away.
But I think we're both learning. I mean, the round one of BCPI, you can save a lot of money if you just ask your patient not to get your cataracts for 90 days.
Right.
So you learn to game the system to say that their spend is lower because you had them get all of their elective stuff done before they were or you come into the ED, we'll make a 23-hour ops, and not a admission, so it's not a readmission. So all these things, eventually, I think, with time, I think, as you said, your information is getting more accurate when you ask for what the spend is. I think 2015, 2016 is where we all ask.
Yeah, true. So for the payers, who ought to hold the bundle? So we get your 90-day spend, we agree to something. We're just assuming that we're going to hold it. But who do you think should hold it? Who should receive the money? One word answers will be fine.
I very much, if we can partner with an independent physician, that's probably like the biggest win-win for all parties involved. There's a lot of third-party, entities out there that are, convening, but I just think if we can contract with the physician, versus the health system or an ASC, that's what makes the most sense.
Okay. Any other answers?
Yeah, what a common thread I heard this morning is the physician, the surgeon should hold the bundle. We expect with Insignia to have multiple options. So if you have the surgery center that wants to be the quarterback, that's the term we always use, a hospital quarterback addition as well. But resounding common thread I heard today was the physician should be the quarterback.
You agree, Wanda?
I do agree. We don't have any other prospective bundles, but we have a retrospective bundle that is in the transplant space that is held by a health system, and has presented some challenges.
Yeah. So another question on the, you mentioned other bundles. So orthopedics and total joints tends to be in the crosshairs because hips and knees are so common. It's the number one spend in Medicare. So that tends to be where people start, and then it's kind of concentric rings outward. What other spaces, what other bundles are coming next? Some of the CEOs in the room might be interested. Is it gallbladder bundles or pregnancy bundles or what's? There is such a thing, by the way. Don't laugh. There's a pregnancy bundle.
Well, we're looking at a lot. Maternity and oncology are two that are pretty high on the list.
Okay.
Don't ask me for a date when we'll be in one, but we are definitely looking.
But the experience of total joints first then helps you create.
And that was the strategy we took. Yes.
Okay. Anybody else?
So, we have a maternity bundle built. We don't have any contracts in place, so that's obviously what we're interested in expanding. We have, we're looking at hysterectomy, and we're looking at
I want to ask questions about the pregnancy bundle, but I'll do that at every last one because that just sounds weird to me, but that's okay. I'm sure you can save money. 30%, I don't know. Jordan, anything?
Well, I'd say medical bundles are probably next on the list. COPD,
Like stroke and-
CHF,
Okay.
chronic condition. So
Okay.
we're currently today,
Got it.
we're in oncology, we're in GI, we're in GYN, we're in maternity, and orthopedics. So
Okay.
yeah, I would say definitely chronic bundles are next on the list.
Okay, a couple other questions and then we'll break. Stefan?
A follow-up on your previous question is, there's a huge influx of physicians into employed status. And I'd like to ask the panel, how does that impact their strategy of negotiating bundles? Because you really can't negotiate a bundle with an employed physician. And how can we reverse that trend? Because I think it's very unhealthy for healthcare.
So the question of.
I mean, in my mind, like, it's to compete with them. You know, if there are some independent physicians left in the community, then, you know, we're driving volume there. Then the hospital systems are going to be forced to deal with that over time, or they're going to lose all their volume.
To piggyback on that, we're seeing in Grand Rapids, we have a big hospital system in Grand Rapids. They have the biggest medical group in Grand Rapids, traveling on PCPs. And those PCPs are directing their orthopedic surgeries to their in-house hospital, and they don't have an ASC. So all of those being done in hospital by physicians, by orthopedics that are not as high quality at all. So they're going to have worse outcomes and all that. But that's where they're steering them on, to be directed by the suits at the hospital to do so. What are you guys doing to control that?
I mean, you know, like we say this a lot, like, you know, we're doing a lot of value-based programs where our goal is to keep independent physicians independent. But like there are a surprising number of markets where it's too late, right? Like there are not. You know, it's a health system that has everybody. You know, and you know, there's not much we can do there other than negotiate the best deal that we can. You know, and you know, we don't really pay for that, right? Like it just gets passed along to the people that are insured, right? That's the claim for.
I guess with MedCost and then Frederick, you guys have the opportunity to just say, we're not going there.
Yeah, somewhat. You know, we're in a market in western North Carolina where we don't have a lot of competition in each community. So it's becoming harder and harder, especially when you got the Goliath health systems that are starting to gobble up primary care. You know, I really think it's going to require the employer community to be willing to be involved in this decision as well and begin to influence through plan design where their employees go. And they're really faced with, they can't sustain the kind of increases they've been experiencing. Otherwise, they're going to opt out and go to a single payer system, which I don't think anybody in this room wants. And so the employer community themselves are the one that's driving it in western North Carolina. There's not a Dr. Lucy in Asheville doing this. It's the employer community themselves that are opting to send their employees to value-based care centers and directing that through their plan design. And so free market is going to really, as long as it has the opportunity to play, will begin to have an influence here. And it's incumbent, and that was part of Wanda and our discussion yesterday, in that we get promotion, communication, and education out to the employees themselves so that the patient that's going to be selecting that care understands what is available and it's not hidden behind some magical curtain somewhere that they never get to look. And they're not just taking Dr. Local's recommendation, they are really getting educated that there are options and their plan design requires them to look at those options.
Yeah. There was another question. Yeah, Grant?
So for those of us who are going to go back and try to talk to your counterparts in our community, and as the surgeon talking to the payer, what buzzwords or pearls does the surgeon need to mention to get your attention that we're somebody that is a great potential partner?
Start off by saying you're willing to give a 40% discount.
Yeah.
That'll get attention.
Just went up.
From inpatient,
That's right.
from inpatient
Yeah, just for the facility. Anyone else on Dr. Zarzor's questions? What does he need to do? Guy came here last year, great surgeon, leading the way. We got to get the guy a bundle contract.
You need to move to a state that's not dominated by the Blues, I think, first. But, I mean, from my perspective, for Aetna, I mean, you just need to tell them, you want a contract, you're ready to sign, and move forward.
That last statement, I don't think I need to.
Well, I can tell you what sold us, and again, you can't have Donna, but they have been very hands-on. They have showed us what their program, how their program was different from the clinical interfaces to the automation to the guaranteeing us that they were going to control the bundle. So for us, it is about the patient care, and then it is about the automation and the solution and the operation. So that was what convinced us that that was the right direction to go. And then obviously the savings was also very attractive in how we could then market that as a reimbursement policy. And so that's how we got hooked, was Donna.
So by partnering with Valere, Donna and Rebecca can be involved in the phone calls with me and help me get this accomplished. So it's doable.
Done deal, baby. Happy to help.
Well,
I got a call tomorrow, my 5th call with the head of network contracting for the state. We sent him a formal proposal, and we're going to have a meet with Dr. Lucy in May at the national conference. And we have a new CEO of Alabama at Blue Cross. There is hope.
Sounding good. It's going to happen, Grant. Hang in there, brother.
In my career,
hang in there.
it's going
Keep
to
coming back to Greensboro. Dr. King.
Yeah, I know.
I've been doing prospective bundle payment now for a little bit about the same time. And I live in a community with a couple of 900-pound gorillas. And so there are very few private orthopedists left to even do this. I'm probably the only one. It's been a great experience. I think we found that it really simplifies things. Just from the paperwork standpoint, it's a breath of fresh air not to be getting paid by the medical record. One of the threats that comes from the gorillas is that, yeah, you can do this for now, but we'll shut you down because we have a lot of influence with the insurance companies. And we'll find a way to just cancel your bundle. Do you see that as a possibility? Are you willing to see that happen just because you'd like to keep a contract with the gorilla and you see me as not anything of much importance in your network?
That's a great question. Very insightful.
No, I don't see that.
Yeah, I'm definitely not the right resource at Blue Cross to address that, but I can see where that would be, you could have some of that. I would hope we wouldn't act that way, but that's our answer.
Wire or wire?
Yeah, I mean, I'm not going to say that that's impossible to happen. I mean, it hasn't happened yet with any of our bundle providers, but, the reality is, like, if they're an 800-pound gorilla, they're an 800-pound gorilla with us, too, and could essentially lock us out of the market. So, it's not impossible for that to happen.
That's a good, honest answer. Jordan? No answer?
I don't see it happening. I see this as really a counterbalance to the 800-pound gorilla. And without you all being willing to step up and do this, we don't have a fighting chance.
Dr. King's been doing outpatient joints longer than we have, so we're going to get him up here and let him teach a little bit more. Ask him some questions too. Any other questions? Donna?
I just really want to make a statement. First of all, just thank you to all of you for being here tonight, as well as the other payer counterparts that are in the audience. You have actually allowed me to get in there and find out what some of the problems are and work together and have conversations that are tough and try to understand each other. And we've spent a lot of hours together, and it's not easy on either side to try and get this to work out. So I appreciate that. I appreciate all the work that's gone into trying to make this happen. It's very slow. It's very difficult, but we all have the same goal. And it's worth it. It's worth it to try and get there.
Thank you, Donna. Any other questions before we break?
Why is Humana not here?
Because I didn't invite them?
Not a large commercial player in this area. And we were presented with a bundle from their, what was that?
We haven't talked to them since.
It was, and so that's why they're not here.
Yeah, some of you have been presented with the same Humana bundle, but I'm sure they're good people, and maybe they'll come back next year or something. Okay, so what's next? So in the morning, again, clinical pillars, business pillars. We'll have breakfast ready at 7, and we'll begin in here at 8. And it's going to be a really, really educational. It's really just the unpacking of the program from the clinical perspective and the business perspective. Feel free to grab any of the surgeons or the other Valere partners or Donna. But again, the next couple of hours is really about you interacting with the payers and figuring out how to make this happen in your community. That's the most valuable thing we can at Valere can do, is just to introduce you. So that's what this is about. So good luck with that, Sean. Get ready to be courted over there. I think he said 3 months and 10%. No, but really, thank you so much to you guys for being willing to come. It really is probably one of the first times in the country that we've had this kind of representation from payers in the same place on a panel, especially being willing to receive questions from an orthopedic surgeon and a group of surgeons. So a lot of bravery to make it to town tonight. So we really do appreciate that. For those who are interested, there's going to be a tour of the surgical center. If you haven't had the opportunity to see it, it's across the street. It's literally right out the windows there. Our CEO, Jenny Graham, is here, and she'll walk some folks over for that. If you want to go, it's beautiful. And while you're doing that or just using the bathroom or whatever you need to do, the proximity will bring in, set up a bar. We'll have food in the breezeway, bar in here. We'll open up the veranda and enjoy some nice North Carolina weather. Thanks so much. We'll see you in just a bit.